Okay, now let's get started. I'm excited to introduce you to our keynote speaker, Dr. Khuram Arif, I practiced that, Medical Officer of Sacramento-based Western Health Advantage, a board certified pediatrician. Dr. Arif practiced for 19 years. He keenly understands challenges facing physicians and advanced clinicians and the imperative of preserving the joy of practice. Dr. Arif spent a decade in physician leadership, helping doctors transition from volume to value-based care. Most recently, he served as Chief Medical Officer at Woodland Clinic and Medical Director of Managed Care at Mercy Medical Group. So please welcome Dr. Arif to the stage. I will stop sharing my screen and we will invite him to share his.
Hi, Laura, Jeff, Aubrey, very nice to join you guys. Good afternoon, everybody. Can you hear me? Let's just do a quick mic check.
Yes, we can hear you.
Okay, wonderful. I'm going to share my screen here. You should be able to see my slides.
Not yet.
Oh, you got to press the share button.
Here,
There you go.
they're coming, yeah. Okay, we're all set.
Okay, folks. So yes, thank you for having me. My name is Khuram Arif. I work right now as the Chief Medical Officer at Western Health Advantage, which is a local health insurance company. And my talk today is going to be a little bit talking about current state with COVID-19, where we were before, where we are now, and then probably spend a lot more time looking at where we need to be in the future. And I'm hoping that the participants will get some insight into where the needs are in the healthcare system side, whether it's healthcare delivery on the hospital medical group side, or it's healthcare financing and delivery support on the health plan side. So just a brief, you know, as I was coming up with this talk and giving some thought to it, I was wondering, you know, we're talking about COVID-19, the future of COVID-19 and the future of healthcare in the post-COVID-19 world. And really, I thought to myself, is there a future? You know, I sometimes with all that we've been going through for this last pretty much year, it can be difficult to have hope. And so I wanted to put up this art piece by Banksy. As you know, he is a famous British / some people say Irish painter, artist, and I really loved this little piece up here saying, well, there is always hope. And so let's talk about that, and let's talk about where we see the needs for the future so we can support our patients, our members, our community. So just quickly, a little background on Western Health Advantage. We were founded in 1995 by two large health systems, Dignity Health, which is, as you know, here in Sacramento, and then North Bay Healthcare, which is over in Solano County, Napa area. We right now have 103,000 members who are mostly commercial members. And then we have, of course, members coming in through the Covered California Exchange. And then this January, we are launching into Medicare Advantage. And for folks who are not quite aware of what the difference is, a commercial member is somebody who is 65 years and below 65 years of age, who is, you know, employed, and is getting insurance through their employer. Covered California Exchange members are folks who are either buying insurance individually on the Covered California Exchange for themselves, or they're small employers who are, you know, less than 50 employees, etc., purchasing as small employees through the Covered California Exchange. And then Medicare Advantage are folks who are actually 65 and above, basically Medicare age patients who are going to be purchasing insurance. We have 240 employees in Sacramento, and we absolutely love working here and being in the city and being a part of the community. So our perspective really is, you know, we are about 3,000 physicians stretching in the area from Sacramento County all the way up to Marin. We have 13 hospitals in the system. And, you know, I think that's the perspective of, you know, how we're looking at COVID-19 currently, and then what our needs are both right now and also for the future. So interestingly, you know, the earliest COVID-19 patients in the United States actually went to our hospitals. These are the folks who you remember were flown in off the cruise ships into Travis Air Force Base. And so we began to sort of have the experience of what it is like to take care of COVID-19 patients within our own systems very, very early on. In a way, I think we began to prepare quickly for going and, for going into shelter in place. And so the day after it was announced here in our area, we were 99% remote operations pretty much overnight. We had been prepping for it for a few weeks because we anticipated coming. And the biggest issue I think for us was the need to stand up telemedicine as quickly as possible. While we had some telemedicine presence, and that means the ability to sort of remote into for a patient to remote into a virtual clinic or office environment and see their clinician, it wasn't really very widely adopted. But obviously, with shelter in place, clinics were shut down. We had to quickly start up the ability to access our patients so we could avoid disrupting their care. And at the same time, hospitals had to rapidly stand up COVID-19 units while canceling elective surgeries, which is pretty much the bread and butter of where hospitals make their business. So it was a matter of pivoting as quickly as possible. And healthcare delivery actually went from 0% telemedicine visits to about 10%. Initially, it was about 25-30%. Now it's settled down to about 10% of our total visits are through telemedicine, and I'll show the actual raw numbers what that looks like. And at this time, hospitals have rejiggered their system a little bit, so they are able to provide your regular hospital elective care as well as provide COVID-19 care, with the extra precautions and safety procedures, et cetera, that goes into that.
Dr. Arif,
Yes,
we've had a request from our audience if you could show your slides in presentation view.
Yeah, let me try that. Sometimes it messes up the cameras, but sure, I'm happy to do that.
Yeah, if you go from current slide, you should be okay. Down at the icon, yeah, that one.
All right, is that better? Okay, good. Thank you, audience. I'm glad that somebody's awake and participating. So, current state basically is that remote work we know is here to stay, not just in other industries, but certainly in the health insurance industry. And health plans have pretty much announced that they will be working remotely well into next year. So we are re-looking at our office space and trying to figure out, well, how does office space get used appropriately? How much do we need? We are having a hybrid approach where some people are coming into the office, managers, leadership folks, as well as office workers who need to be in the office from time to time. So how do we sort of redesign our spaces, make them sort of much more community oriented, much more of a workspace sharing type of approach? And we probably need some help figuring out, what's the best approach with using our workforce and our workspace. In addition to this, just from the perspective of a business, and I'm sure that we're not the only ones saying this, but basically there's a need for robust and intuitive office communication platforms. When I say intuitive, I mean, if you are taking a meeting from your cell phone, or if you started taking a meeting on your desktop and then you needed to switch to your cell phone because you were driving or whatnot, that's one of those things where we do not experience seamlessness. How do you transition from one kind of platform to another and keep that whole communication that was happening going on without being disrupted? Ready access to your work desktop, including the single sign-on to multiple software tools. Many of us have it, some of us don't. How do you, for example, access again information? Nowadays, with so much being on mobile, how do you go to a place where Zoom on mobile or your WebEx on mobile works as seamlessly as it does on the desktop? While we have it in theory, when you actually go to practice it, all kinds of frustrating things pop up and it becomes hard to sort of troubleshoot that. So basically looking at interfaces between the different communication platforms, but then also looking at affordable interfaces. We in the helpline industry use so many different tools. For example, we have one system to analyze our claims, which is basically our bills, to keep an eye on the costs that are being incurred by our members. We're also looking at data tools. We're looking at communication tools. But at this point, for example, I think we have a suite of, 50 or 60 different kinds of electronic tools just within our own small health plan. which don't really talk to each other. You know, we've got large tools like whether it's a Cisco system or Salesforce for customer relationship management, but how can we figure out how these can talk to each other and be seamless? So that is certainly a need that we experience. And then, does anybody know how to manage email efficiently? And I'm talking about an inbox which is smart, or a sent box which is smart. You know, we all know how difficult it is keeping track of this, and we've been dealing with this for years and years. But how do you get to the place where you have intuitive or a smart email management system, so that when you are, for example, trying to get to a electronic invite for a meeting, your inbox, you know, in that space, in the invite space, automatically pulls in the relevant emails that you might have received, so that you can look at content. If somebody forgot to attach the agenda or forgot to attach the minutes, etc., how do you pull that up very, very, very quickly? And then calendar management. How does the calendar management get intuitive? And why is this different from where we were before? We've been in this space of inefficient, you know, business practices using the electronic system for a very long period of time. But I think that because of the fact that you have, you know, when you were working in the office, you had people you could talk to, you had folks who could help out, you know, some people could jump onto something right away and get it done. We don't have that luxury now, right? We have to schedule our virtual meets and conversations. So a lot of management has to be done by folks themselves, and we are not intuitive. And certainly our systems supporting us are not. And finally, privacy and security is a huge deal when it comes to healthcare data. Privacy and security is a huge deal across the board. We all know this. But the healthcare industry, just for folks who may not live and breathe this industry, is especially regulated. You know, for example, we have laws around, you know, the HIPAA laws, et cetera, that, you know, regulate specifically how is information going back and forth in the health space. Protecting the privacy and security of that is huge. And we know this because right now, as an example, a lot of physicians and clinical folks are using Zoom as a tool to, you know, thankfully this tool is around and was able to stand up real fast to have office visits and to take care of patients. But, you know, how safe is that environment, and what is being done to, whether it's that environment or another platform supported environment, how safe is it, and what can be done to enhance that privacy and that security? Then finally, and the next on this list of current needs with respect to, you know, operating the business is that virtual boardroom enhancement. We all know, we've all, I think, spent this whole year sitting around, some of us are sitting around tables with a camera at one end. You can see two people on the screen, the other four you cannot. How do you make that so that feels more like a real presence? All right, let's jump forward and talk a little bit about telemedicine adoption. Now, I know that our fellow, you know, panelists and other speakers are going to be diving into this in some detail as well. But this sort of shows you quickly just our own experience. You know, the blue line.
RF,
Yes, ma'am.
I'm sorry to interrupt you again, but we're still not seeing the slides in presentation view.
Let's see, it looks like it's showing at my end. You know, while I know it's not, it may not be efficient all the way, should we keep going forward? Because from my end, I've got this thing presenting and I've got the slide up on my screen.
Okay, let's just move forward then.
Let's move forward. Hopefully, I mean, the slides are big enough that hopefully folks can still manage, even though it's not perfect the way that we all like it.
Okay, thank you.
If that's okay. Thank you for being patient with the virtual space. This is exactly what I'm talking about. We need some intuitive folks so that people, you know, who fumble with technology like myself can get some intuitive help. So this is a perfect demonstration of what we're talking about. So just in front, on the screen in front of you, you should be able to see the telemedicine visits, which are in the blue line, and you'll see that all the way up till February, right up till about over here, you should be able to see that we were pretty much like, you know, close to a baseline of 0. And then telemedicine visits sort of took off, and we hit a peak of like 7,000 visits over just a space of a month. The orange line is the our regular office visits or in-person visits, and you can see how they sort of had, really sort of have dropped quite a bit, and then they recovered a little bit as time has gone on. So you can sort of quickly see that, yeah, telemedicine adoption is very much the norm over here. Okay, let's see if we can jump forward. So, talking about healthcare delivery changes that have been driven by COVID-19 per se, of course, the exponential adoption of telemedicine is a big deal. And this is a big deal not just because we are suddenly using a new mode to communicate with patients, but it's about the culture itself. As a physician who practiced for a long time and led physicians, it has been incredibly hard to actually get doctors and clinical folks to agree to using telemedicine, just because it's not really an amazing substitute for seeing the person, your patient in person. However, with necessity, telemedicine became adopted. It was adopted because we had no choice, and now we're finding that doctors and patients are actually liking it. And that also suddenly means that consumers actually have gotten into the driver's seat. For a very long time, the healthcare system has been focused on delivering care the way that the healthcare system feels it should be delivered. And certainly, as a physician who practiced for a long time, we've walked that walk. But now we're realizing, you know what, if we cannot deliver telemedicine, patients are not going to show up. And that's what's happening right now. People are not coming into the doctor's office because they're afraid. And so that means that the consumer suddenly is in the driver's seat. And for the first time, health systems are actually having to aggressively listen to what the consumer is saying and then try and meet that moment. So the physician-patient communication platforms need to evolve. Um, and the physician-patient monitoring platforms need to evolve as well. Okay, so let's jump ahead over here. So what is an important care and innovation need? I pulled this, I pulled up this little screenshot, and you can see that the patient here is Captain James Kirk, a famous personality. I'm sure you all know him. And, so many years ago, um, our entertainment industry had imagined what a smart health record would look like. And we are nowhere near close to this, right? We have all kinds of siloed health records. There is no way for me as a patient to be able to look at my health record in one place. It's not seamless. I may have portions of it in different platforms, depending upon where I got care and which health system is providing me what kind of information. But there is a need for a comprehensive, integrated, smart health record. Medicare is moving under its new interoperability rules, is trying to move us into a place where health systems will talk to each other and information will flow freely. But we are light years away from that, and we are many multi-millions of dollars away from that as well. The next thing that we are looking for with respect to health delivery is, how well is the healthcare system able to accompany the patient? Right now, the way our systems are set up, we are waiting for people to engage. And once they engage, then we are like, hello, who are you? All right, now I know who you are. Let me identify you. Now let me provide you the service that you need. But we are doing this in a disjointed fashion. I don't say this as a way to lecture. I just say this as, what the reality is. For example, I go to the pharmacy, right? And I want to get my flu shot. And I'm not sure as a patient, what is my copay for the flu shot if I'm at the pharmacy? Is it different if I go to my doctor's office? Can I even get a flu shot at this pharmacy? Talking about flu shots because that's top of mind right now. But basically, is there a way for my health information, whether it's my benefit information as a person who's bought health insurance, or my medical records information, what my last labs were, etc. Is there a way for that to follow me no matter where I am? Whether I'm really sick and in the ICU, if I'm going for a follow-up visit to my doctor's office, if I'm checking my blood glucose at home because I have diabetes, or if I'm actually picking up medications at the pharmacy. So, the healthcare Internet of Things is sort of, we're seeing it, but it's not really arrived. And so that's something where we definitely have a need. I saw a question come up on the screen, but I think we're taking questions towards the end. So Laura, I'll just let you cue me if you need to jump in and ask me a question. Healthcare innovation needs patient autonomy is a big deal. Just how much can somebody control their own health needs? As a patient right now, many of us may feel disoriented or even helplessly moving along in a system, why? Because if I need my electronic health record, some systems are already doing this, but not all are. I don't really have a way to access it until and unless I'm within my own parent health system. For example, if I'm getting care oh, I'm sorry, I jumped ahead. Let me just go back here for a second. If I'm getting care from, let's say one of health system A, but I'm now in the emergency room that belongs to health system B, how can I show health system B what my previous care has been? I don't always have ready access to it. And so what that means is that we need an electronic health record that is not tethered, not tied to the place where I get my help normally. It should really be tied and owned by me as a patient. In other words, where is my autonomy? I don't really have it. And then that patient chart needs to be dynamic and communicative. For example, geolocation, right? If I am going to the pharmacy, or if I'm searching for a pharmacy, my system should be able to tell me, here's the pharmacy that's in your network, for example, and if you go over here, you'll find the medicine for a lot cheaper. And that should be possible without having to go into my parent health system's electronic system, electronic records. What do I mean by that? Do I have an app on my phone that tells me everything I need to know about my healthcare, whether it's benefits or my medical records, no matter where I am? And so I'm just sort of reinforcing the previous slides. So wherever I go, can I sort of plug my information into whatever system I'm accessing? I'm sure that there are other people thinking about this as well, but certainly from our perspective as a health plan, and from hearing the members' perspective, we are looking for some kind of improved seamlessness. Finally, with people now actually getting onto virtual visits from their homes or from their workspaces, we have doctors, for example, who are seeing patients who are actually on their work break. We have various kinds of health stations out there. We've got really, really expensive robots. You'll remember Big Hero 6, which is an awesome movie. My kids love it, where you had this really friendly robot who took care of your spiritual and your medical health, and who seemed to have all the answers and, in one place. And this is something where they may well be opportunity, developing small remote personal health stations. Now, we all have phones, and I am noticing, for example, that various people are coming up with different kinds of scopes. You can plug this scope into your phone, and you can probably take a listen to the heart, and you can take a listen to the lung, or as a patient, you can hold it over your heart while the clinician at the other end is hearing, what they need to hear. But just how effective are there? How useful are there? And is somebody sort of trying to put all that information in one place? For example, I need a different scope to be able for the doctor to be able to look down my throat, versus I need something different for the doctor to be able to hear my heart. How can I get this all in one place? And then finally, if I'm going to be checking my blood pressure and my heart rate and my pulse and the respiratory rate and all of that stuff at home, how do I know that I'm doing it correctly? Now, there are really, really good systems out there that have the ability to do this, but again, they are very sort of choppy. And there's one company, for example, that might be focused on providing remote monitoring devices for congestive heart failure patients. But what about for your regular patient? How do we make it so it's really cost effective and it's available at the in a way that's friendly to consumers? And then finally, if my exam that I do on myself with my on devices is unusual or abnormal, how do I know that that's truly abnormal and I need to take action? And then how is that plugged into to my health system or to my doctor's office? Finally, turning towards responsiveness. As a healthcare industry, we are not alone in trying to get surveys. Recently, I was looking for a handyman and I joined up onto an app to find a handyman for trying to get a bathroom baseboard fixed, and God knows I can't do it. So join up onto this app and I got a couple of numbers, and then the next thing you know, literally within 10 minutes of joining, I'm getting a survey asking me how well is that app performing. And you can imagine just my frustration with that. And I'm sure other people have higher frustration tolerance than Dr. Arif does, but certainly we all feel that everyone hates surveys. Nonetheless, as somebody, as a health system or a health plan trying to deliver a service, we want to know, where is the consumer? Where are they in their journey? How happy are they with the service that they're getting? What can we do different or better? And currently, the way that we do this is we use very prescribed surveys, which are, regulated by CMS. They're, you do them over over a 3-month period. The look back is 6 months before, the 6 months ago when you got a visit with a doctor. Now 6 months later, I'm being asked to survey that visit. The information gets to the health system, 3 months or 4 months later. So obviously, this is not smart. It's not real time. It's not actionable. We need to be in the middle of the action. And could we use technology which actually is fun for people, which actually engages people? What's so interesting is recently I was looking at the news, and one of our freshman congresswomen got on this game called Among Us, which I've never heard of and never played, but apparently that was their way to connect with their constituents. And apparently, several million people joined, or several 100,000 people joined, just because that one person had joined the game at that time. So can we think outside the box? Can we make surveys which are so important for us to be able to decide what is it that the customer is looking for, real time and fun? And can we do, interesting and different things like gamer technology? If Congress can adopt it, perhaps we should be thinking in something in a different way as well. Okay, so jumping forward, and again, I'm happy to stop for questions whenever you feel, Laura. So healthcare innovation needs basically customer relationship management. Sometimes people feel that their experience might be like Arthur Dent's experience, with a really scary looking clinical person who they're not sure is necessarily sincere to them. We'd like to get to a place where we have folks who are happy to see you and who obviously are interested in your care and your well-being. And it can be very difficult because this is not taught in a routine or systematic fashion at a lot of medical schools and residencies, and perhaps at the places, where vocational schools where medical assistants and nurses and front desk staff and call center folks are being trained. So it's very, very expensive to bring in a real person to do this in real time. We've done it. We've actually brought in coaches who can observe our physicians, our clinical people, our front desk people interacting with patients and give them real-time training on the spot. But you can imagine how resource intensive that is. So is there a role for AI to develop, to be used to develop self-help and self-learning modules for healthcare personnel, which are focused on how to deal with the customer and to take the focus away from the patient as being a recipient as opposed to the patient being an active participant in care. Okay, so jumping ahead, Apple is doing some interesting things. I threw up their new information on their new health platform on the Apple iWatch, because it's really interesting what they're doing. They are, now you can get your own EKG, which is electronic readout of your heart rhythms through your watch. You can, obviously, we've known for a while, you can see how long somebody's been sleeping, what was the quality of their sleep. In fact, if somebody falls down, you can get alerted that there was a fall. So obviously tech is moving in the right direction. How do we now get this plugged into the health system itself. For example, if a patient of mine, as a doctor, if a patient of mine, 85-year-old patient falls in the middle of the night at home, how does the health system get alerted? And who should get alerted? Should it be a monitoring station? Should it be, if it's somebody like, like the Philips, the Life Alerts or whatnot of the world, how they plug into the health system? We have a lot of standalone stuff, a lot of standalone services being offered, but how do you integrate that with the current healthcare being delivered so that when the doctor comes into their office the next morning, they know, they find out, oh, Mr. Jones had a fall last night. EMS did get out there. They transported the patient to the hospital. The patient is now, and Ms. Jones is now admitted in this hospital on this floor, and these are his morning vitals. This seems like something that is, from my perspective, it's almost like impossible. It'll probably never happen. But this is where I think our job is to share with industry and technology pioneers like yourselves where the needs are. I think I'm pretty much at my last slide. All right, here we are. So I guess the question is, can you help us to innovate? And how can we partner with you in arriving at answers? So thank you. And with that, I'm happy to take some questions if we have time.
Great. Thank you, Dr. Arif. We do have a few questions, and if we don't get a chance to go over all of them, afterward, I believe you can go into the chat or into the Q&A and type in some answers if you want. But the most popular question is, are you seeing younger patients using telemedicine more than older patients? Are there demographic trends to telemedicine use?
It's an excellent question. And you would think that, intuitively, the younger patients would be using telemedicine more than older patients. It's still a little early for us to really look and understand demographic trends. But at this point, we are seeing a lot of patients in their 60s using telemedicine. Because if you think about it, it's often, me too. Yeah, recently, my dad actually had a fall at home, and I was able to get on with him and his doctor. And my dad was able to talk. He's 85 years old. He's able to get on the thing and talk with our doctor. It was just amazing. But if you think about it, it's really often folks who are older, middle age and older folks who need healthcare. So they're the ones who are more likely to really need it. Therefore, they will adapt to getting new technology. For younger folks, where we're finding interesting is we are finally able to get a hold of young people saying, well, you know what, this is convenient. Young folks want convenience. People in their 20s and 30s don't want to leave their job if they don't have to, don't want to leave, take time off, etc., to see the doctor. But they need healthcare. So for them, it's convenience, and for older folks, it's the fact that the technology is not that hard to use once it's made available and we know how to use it.
Great. All right, then there's a couple questions kind of targeted at you as an insurance provider. The question is, why are there expiration dates on the use of telemedicine coming down from the insurance companies to the providers? And then it's sort of a tag-on question to that. What would have happened if payment rules had not been liberalized?
I love that question. And Rachel, I appreciate you asking that question. This just sort of shows why we need, we as the health plan or health insurance industry need to understand what is our consumer looking for, what is our client, our member looking for. And honestly, if the whole telemedicine rules had not been sort of waived and the whole HIPAA security stuff had not been waived very, very quickly by the federal government, which was a real blessing. They moved very quickly on this. That really sort of opened the pathway for us to be able to, first of all, even offer this without being terribly worried about, well, we have to go through 6 months of security checking, etc. The second piece of this is limits on telemedicine. So I will tell you that having that currently participating in forums for health insurance plans across the country, this is exactly where we are going. In fact, a health plan like ours, Western Health Advantage, we've basically announced that as long as this COVID-19 thing is in place, we are going to sort of be covering telemedicine visits for COVID-19 without any copay costs. And also, in addition to that, even whether there's COVID-19 is here or not, we have decided, and so have many of my fellow health plan colleagues from other plans, that co-pays for a telemedicine visit will be treated exactly like you were doing an in-person visit. Should it be a little bit less? Perhaps, but there's also a convenience factor that we're able to provide. So it comes out in the wash, but certainly the industry has actually aggressively moved in the direction of lifting limits on telemedicine access, but not everybody's caught up. So, but the industry is going that direction.
Okay, that's all we have time for, but our next our coming up is kind of an extension of your talk, and I think we'll leave those questions there, and we can ask that of the panel. All right, so, and also in the meantime, if you'd like to, if you want to go in and make any comments in the Q&A, I think you can do that, Dr. Arif. So thank you so much. It's fascinating how quickly the delivery of healthcare adapted to the changing needs during this pandemic.